Hello, everyone. This week we are covering age and body image. The first article that we read was Save the Young, the Elderly Have Lived Their Lives, Ageism in MFT. So, Ivy and colleagues talk about ageism in marriage and family therapy and examine how age-based stereotypes and structural biases shape assessment, treatment, and even resource allocations, and then ultimately suggest what we can do differently. So, what is ageism? It is prejudice and discrimination on the basis of age. It appears in two main forms. There's benevolent ageism that sounds caring but is paternalistic. For instance, assuming older adults can't decide for themselves. And then there's hostile ageism, which is openly negative. For example, seeing older adults as burdensome. Both show up in everyday language, expectations in session, and clinical decisions. In family therapy, age-based hierarchies and roles are already salient. Late life work often includes adult children, spouses, and extended kin. Our stance on age profoundly affects autonomy, safety planning, and quality of life goals across the whole system. The article's title signals a common triage narrative. Prioritize the young because the elderly have lived their lives. When this logic is unexamined, older adults are subtly deprioritized, resulting in undertreatment and exclusion from specialty services and supports. Ageism fuels diagnostic blind spots. We may conflate normative aging with pathology, or conversely, miss depression, trauma, or substance use by chalking everything up to just getting older. The article urges much sharper differentiation among normal aging, grief, medical comorbidity, and neurocognitive disorders. Benevolent ageism is tricky. It feels kind, but it sidelines agency. Examples include elder speak, ritualizing doing for instead of doing with, and safety plans that ignore what the older client actually wants. The authors push us to restore voice and choice. On the hostile side, we see blame narratives, older adults as non-compliant or set in their ways. This primes systems to minimize late life outcomes and can justify coverage limits. The article links these patterns to structural ageism in policy and organizational practice. Ivy and colleagues argue that MFT training rarely equips us for late life complexity. Core gaps include evaluating decision-making capacity, screening for elder abuse, navigating guardianship, and working in caregiver intense systems with burnout, grief, and ambiguous loss. Practically, the authors recommend 4 shifts. First, screen for depression, anxiety, substance abuse, and elder abuse as standard. Second, coordinate with medical and neuropsych professionals. Third, fully map the caregiving system, roles, conflict, and burden. Don't assume you already know who does that. In treatment, anchor goals to what the older client values, person-defined outcomes. Audit your language and rituals for any infantilizing drift. And when safety and autonomy collide, make the trade-offs explicit, collaborative, and well documented rather than defaulting to paternalism. Supervision should invite reflection on our reactions to aging, dependence, and death. Team case conferences can include explicit checks for triage biases. Ethically, we're called to challenge age-based exclusions, whether in referral patterns, program criteria, or informal gatekeeping. So the take home here is that ageism is subtle and systemic, but we can fix a lot in everyday practice. Upgrade training and supervision, partner across disciplines, and center autonomy and dignity. Above all, treat late life outcomes as worth our best clinical work. So moving from age to weight. So summarizing, this article summarizes a national survey of 162 marriage and family trainees, and that documents explicit weight bias, highlights who is most at risk of holding particular biases, and outlines training implications for ethically responsive, family systems informed practice. So why does this matter? In MFTs, clients' health and relationship problems are intertwined. Weight stigma is widely documented in healthcare, education, and other sectors, and it carries short and long-term harms. Ethically, AAMFT requires us to provide services without discrimination, which includes body size and weight. The study measured explicit, meaning overt, anti-fat attitudes and beliefs among MFT trainees and examined how demographics, BMI, and experiences relate to those scores. Participants completed the attitude toward obese persons, belief about obese persons, and the anti-fat attitude scales alongside background items. So the ATOP, the BAOP, and the AFA. So interpretation matters. Higher ATOP or the attitudes toward obese persons means more positive attitudes. Higher BAOP or beliefs about obese persons means stronger endorsement that obesity is not primarily personal willpower. Higher AFA or anti-fat attitudes overall and on dislike, fear of fat, and willpower means more explicit anti-fat attitudes. Across instruments, trainees showed explicit weight bias. The scales correlated as expected. For example, higher anti-fat attitudes were associated with less positive attitudes toward people with obesity and with stronger willpower attributions. Meaningful patterns emerged. Master's students were more likely than doctoral students to attribute weight to willpower. Women reported more fear of gaining weight than men. Trainees who were overweight or who self-identified as overweight reported more fear of fat, whereas non-overweight and non-white trainees were more likely to view obesity as less under personal control. Notably, having personally experienced weight bullying or having a family member who did not reliably reduce explicit bias scores. Also, several expected ATOP differences did not appear. Trainees report treating weight-related concerns now, yet programs rarely teach how to address weight and body size systemically and without harm. Explicit bias can damage alliance, violate non-discrimination principles, and deter clients from seeking care. The authors recommend self of the therapist work to surface internalized ideals and biases, a family systems lens to understand and intervene in family dynamics around weight, clinic environment audits to ensure size inclusive spaces, and careful consent-based language, always asking permission before discussing weight. Because master's trainees showed stronger willpower attributions, programs should integrate weight bias content early. Supervisors can listen for willpower framing and fear of fat themes, and programs can add weight bias assessment to diversity and self-assessment processes. Use an ask, offer, ask structure when linking health and weight. Normalize and externalize stigma and actively decouple weight from personal worth. After any discussion, check in explicitly. You can ask something like, "What was it like to talk about this today?" And treat consent as ongoing. Clients can always say no or not now. Limitations include a predominantly white female sample, reliance on self-report, and a focus on explicit rather than implicit bias. Future work should center client perspectives on weight discussion in family therapy and test MFT-specific curricula designed for systemic stigma-aware practice. Then some take homes. So the bottom line here is that explicit weight bias is present among trainees. It varies by context and can be addressed. With targeted education, supervision, and clinical design, ethical, size-inclusive, family systems-informed practice is absolutely teachable. All right, so our final article for the week on bias, discrimination, and obesity, evidence, mechanisms, and implications. So we'll review the empirical evidence that weight, stigma, and discrimination are systemic across employment, healthcare, and education, with suggestive signs of other social arenas. And then we'll close with some implications for research, practice, and policy. So why does this matter? This topic matters because stigmatizing attitudes frequently translate into discriminatory actions that limit access to resources. The consequences include worsened health via delayed care, reduced economic opportunity through wage and promotion penalties, and constrained educational trajectories. This review draws on experiments manipulating applicant weight, clinician and teacher surveys, self-reports, and case law. The evidence is strongest for employment discrimination, healthcare stigma, and school-based peer rejection. Major gaps remain around representative prevalence, validated metrics, and several unexamined sectors. So in terms of employment, experimental hiring studies consistently rate higher weight candidates as less desirable, even with identical resumes, especially in public-facing jobs and more so for women. The stereotypes invoked lack of discipline, competence, or fit, which mirror broader cultural narratives. Staying with employment, observational analyses showed a wage penalty for higher weight women and occupational sorting among men. Experiments rate higher weight employees as having lower promotional potential, holding qualifications constant. Several industries have enforced weight standards whose justifications align more with appearance than job performance. And moving to healthcare, across studies, many clinicians endorse negative stereotypes, which risks framing patients as at fault. Dietetic providers also show ambivalence. One controlled education program for medical students reduced bias at 1 year follow-up, suggesting that training can help. Staying with healthcare, clinically, providers report low counseling intensity and few referrals. Higher weight women are more likely to delay mammography and gynecologic screening, citing weight-related embarrassment and prior experiences. Insurance practices frequently exclude obesity treatment, and coverage for effective options like bariatric surgery has been inconsistent. In terms of education, anti-fat bias emerges surprisingly early. Classic and modern replications show higher weight children often ranked least preferred, sometimes below visible disabilities. This climate fuels chronic teasing and social exclusion with measurable impacts on self-esteem. Some educators attribute weight to controllable personal failings. At higher ed transition points, higher weight students, particularly girls and women, receive less parental financial support and face lower acceptance rate despite similar academics. High profile dismissals underscore institutionalized bias. Beyond the big three evidence, though it's limited, this points to barriers in seating and transport, hints of differential apartment access, potential preemptory challenges in juries, and adoption concerns. A methodological note, major studies have sometimes excluded higher weight participants, impeding generalizability. Legally, explicit weight protections are rare, though some cities and states include appearance or weight. Most litigation uses ADA or RA, which is the Americans with Disabilities Act, and the Rehabilitation Act frameworks with inconsistent rulings. Courts often view weight as voluntary and mutable. Perceived disability claims can succeed, but require showing the employer viewed weight as impairing major life activities. Practically, we need clinician training to reduce bias, accessible clinic infrastructure, and proactive preventative care. Policy should address explicit protections and coverage parity for effective treatments. Research priorities include better measures and prevalence estimates, causal pathways, and randomized trials of multi-level anti-stigma interventions. Then finally, some take-home points here. So in sum, discrimination is systemic and consequential. Addressing it requires coordinated efforts, changing professional practice, redesigning environments and policies, and evaluating interventions with the same rigor we bring to other major health inequities.